Kat, for coming to talk to us today. Thank you.
Thank you. It's a real pleasure to be here, and I echo every speaker who said that it's great to be physically back, and it's a bit stressful, but I'll do my best. So following on the amazing Sarah, she took us through really the work that she has pioneered in making sure we don't lump things in interoception together when we shouldn't lump them. And as I'm going to talk about, this happens a lot, actually, not just in interoception. But what happens more often is we lump together, then we realize, no, things are different, let's have categories. But then we don't look at how things get integrated or work together in reality. So this is what I'm going to try to do. So, you know, interoception and monitoring the inside of the body, and we just heard that in the last question, of course, raises the ability of self-awareness, and therefore, what is the self? It's that question we all know, we all can define, we all think we have a self, but if you ask any scholar of any kind to define the self, there's going to be a 10-year debate. But the self is present in all over psychiatry: schizophrenia, personality disorders, mood disorders, etc., and in sort of disorder-based studies as well as transdiagnostic studies. For example, let's take eating disorders or anorexia nervosa. There's a long tradition of finding some concept of the self and relating it to abnormalities in anorexia nervosa. So if you look at clinical psychology, we speak of reduced self-esteem or self-efficacy, self-concept clarity, self-body image problems, increased self-objectification, self-oriented perfectionism, and of course, it's ego-syntonic. And that matters clinically, right? Anybody who's worked with severe, particularly restrictive anorexia would know that even though these patients come to therapy sometimes wanting to get better, they don't want to get better sometimes, or a part of their self doesn't want to get better because they experience the non-eating as somehow serving the self at one level. So it gets a bit complex. But the self isn't just an academic curiosity, it matters clinically. And we have similar sort of multiple descriptions and confusions about the self, including now in the interoceptive field, as Sarah nicely demonstrated, in other fields like cognitive psychology and neuroscience. And why would that be? Well, part of the reason we don't know how these things come together and which of them applies when is because they've been studied by different traditions. So we have the classic sort of thinking, reasoning tradition. We had legal stuff today, so reason is very important for legal responsibility. And we have the idea that, you know, it's our reflection, our cognitive control, our self-regulation that allows us to really know who we are. And in research, that translates as the ultimate knowing of who you are is being metacognitively aware, monitoring the monitoring, as somebody said this morning. Or cognition about cognition, cognitive control, self-regulation, etc. And a lot of the studies, when they define metacognition like that, they look at confidence. So I get you to do a perceptual task, and then I ask how confident are you in the accuracy of your perception. And these are typically retrospective. I perceive first, I have metacognition afterwards. And CBT largely relies on some ideas about metacognition. On the other hand, there's much more to say here, including externalist views on the self, so I'm only choosing two important ones for this talk. But there's another big tradition, more phenomenological, more existential, where the self is directly linked to the body. So it's because I act and sense that first and foremost, I have a sense of giving this talk today here. The concept of myself, despite my narrative or metacognitive elements, is grounded on my body. And of course, interoception research falls more under this domain. And then you have a lot of also other, not just interoceptive, but multisensory studies, and some traditions in psychological therapy, like somatic therapies. So what I'm going to do today is I'm going to choose two disorders, because they are my favorite kind of disorders, that really challenge any functional structural division, any mind-body dualism, because they are clearly somewhere on the physical-mental health interface. So we're going to look at what happens to people that have hemiplegia following a stroke but are unaware of the paralysis. And we're going to look at eating disorders, and particularly extreme cases of restrictive anorexia that obviously a lot of the time don't have good insight into their eating symptoms and their consequences. So anosognosia is more common after right hemisphere lesions. Obviously, you have quite a lot of primary deficits on the contralesional side, but anosognosia isn't diagnosed on the basis of these deficits. It's diagnosed as a self-awareness problem. So over and above them, you do not know that you are paralyzed on the left. And what's been sort of the big question in the field is, obviously, by definition, these patients fail to update their beliefs about their own body. So they're paralyzed, they try to get up, they fall, and they still say, I can move, I can walk. So in that sense, beliefs are delusional. So deficits are denied or they're attributed to false causes. The big question is, for a long, long time, as it is with other delusions, whether this kind of not learning and not updating your beliefs is explained by the fact that you have the sensorimotor deficits, so you don't have the right kind of input, if you like, into your belief system to update your beliefs. I'm going to call that a bodily self-level explanation, or whether we need to think of other more domain general, such as belief updating processes or metacognitive processes, in order to explain why these beliefs are not updated. And this has been a huge debate, as you know, one-factor theories, two-factor theories, is it one, is it two? But very little attention. Well, let's just assume for a moment that it's not an either-or. And even if it's both, how do we quantify the both? How do they actually get integrated? Otherwise, how are we going to help our patients? If we just say it's both, it's everything, it's complicated, it doesn't help. If we oversimplify them, it doesn't help. How do they get together, and can we quantify that as scientists? So it's been trying to do, and that's just a little, what I like to do, bedside experiments with these stroke patients. They're quite hard to do, so the samples are not huge, and the technology is not very high because it doesn't work very well, but we try our best to be clever in other ways. So this is by the bedside, and all you do is you choose bimanual actions, and you ask somebody to give you a prior estimate how well they think in the current state. They're completely paralyzed on the left. They can use cutlery to cut a steak, and what is the retrospective confidence on that? Then you ask them to try that with imaginary cutlery, and then you ask them, how well do you think you did? And what's your confidence on this? So that's a retrospective belief on your performance, which is 0, by the way. I hope it's clear. And this has been done many times. This is just a simple belief updating task. But what we've done for the first time is ask people, okay, now that we've done this, let's say I give you another piece of cutlery. How well are you going to do now? So, or let's say I ask you to do that at home. How well are you going to do now? So we're trying to get people to give us another prospective estimate on their ability. So you had an idea, you observed, how are you going to generalize effectively? And we did another little twist in our experiment. So these patients also have hemispatial neglect, so they have impaired attention on the left side of space. So we did the same kind of belief updating in both hemispaces, on the assumption that on the neglect one, where they have less attention, so they have less precision, if you like, less weighting, less focus on the feedback, what they're learning, they're going to see less that there is a problem, and so that's why they're not updating their beliefs. It turns out we were wrong in a very interesting way, or I think so as well, at least. So this is the intact hemifield. So these are the target patients, and these are well-matched hemiplegic patients without the critical anosognosic delusion. As you can see, the anosognosics for bimanual tasks that they really cannot do tend to think that they can, right, in both hemispheres. In comparison to these patients, although note they're not at 0, and they're also completely paralyzed, right? So what you first see is that after you get them to do something, you do a bit of good old neurological confrontation, they actually drop. And contrary to our hypothesis, they can also drop in the neglected hemifield. So they see, to some degree, not the normal degree, but to some degree in relationship to where they started, they see the problem. I'm paralyzed, I can't use fork and knife to cut a steak. But what's really interesting is when you then ask them to generalize, okay, so if I were to try to do this again, what do you think? In the intact hemifield, they stay closer to what they observed. But in the contralesional, the affected hemifield, or the hemispace, I should say, they go back up closer to their prior. So there's neglect shouldn't have a role here because all the observation happened here. Why are they not updating their beliefs? So clearly something is happening there. And so we used a little bit of maths to try to explain this. I'm not going to go too much in the equations, A, because I will bore you, B, because the mathematicians in my lab do that much better than me, and I don't want to abuse maths. But the basic idea I can explain. So this is a little Bayesian formula of how we update beliefs given some evidence and some prior beliefs. And what we wanted to see is, if that's the task they have to do, where are they paying attention? Where is the weight? Is it in the prior belief? Is it in what they learned? What their new observations? That's really what it's about. And we modeled two things with this maths. One was, what if it's their confidence estimates that I told you about, that we ask them their subjective beliefs. So we put this in the mathematical model as what they weight. If I'm very confident in observing, I should really change my mind a lot. As simple as that. The other thing we modeled is, what about the neglect? So maybe I'm seeing something, but if I'm not paying a lot of attention because of another symptom, neglect, then obviously I won't weigh that information that much, right? So we modeled that as well as another source of precision. And then we ran our models and we see if we compare the actual belief that the patients gave us, their subjectivity at the end, how well are you going to do this next time, with what the model predicts, so an optimal kind of Bayesian belief updating. What you see is that in the intact hemifield, the subjective confidence is closer. So it's closer to what the model is closer to what the patient actually said. But if you look at the contralesional field, it's actually neglect that matters. So even though experimentally, or if you like clinically, in front of you, the posterior belief shouldn't really have to do with how much neglect you had when you observed something and concluded that you didn't do it. And yet, the numbers tells us that it probably does. So even though I admitted failure, somehow neglect, and perhaps the particular lesions that cause neglect, change how I generate posterior beliefs. And this example, I think, makes it really easy for all of us to see why. So this is a very posh gentleman, CEO in a company. And we always ask these questions in the beginning to make sure our stimuli are relevant to people. So we ask him how relevant it is that he's able to use gloves. Of average importance, it's not that I use gloves to do my own gardening or anything like that, just in the winter. And he was very adamant about this, I don't do any manual work. And so then we ask him how well he thinks he's going to do, and he says 7 out of 10. I don't think it will be a problem. Quite confident. And then we ask him to do it. Interestingly, he uses strategies. He doesn't manage, of course, and he says 3 out of 10. And then spontaneously he says, it's these gloves. If it was the ones at home, there's no problem there. Like when I need to do the garden, I can put them on and no problem. It's just now these gloves. So you could say he has some frontal perseveration. You can say a lot of things neuropsychologically, but it's an interesting response that I think gives us a window of insight. And this is a very clever gentleman. I made fun of him, but he's actually very clever. He's been very useful in helping us understand things. And of course, with this response, maybe we're not surprised he's all the way back to 7. So it seems there's this space in these patients where their observations are impaired, but it isn't a totally absent sensory-motor monitoring. Despite the neglect, they can see retrospectively that something is wrong. But when they have to abstract on the affected side, they're unable to do so. It is as though, and I'm reminded of classic behavioural neurologists talking about the affective aspects of neglect, or the salience, we would say today, aspects of neglect. It is as though in this space, there's nothing to be learned about the self. The here and now of this space is of no relevance. Yes, I can see, but if it were the gloves at home. So this left side, now left out of egocentric space, as it happens in neglect, is of little salience to the self. We are unable to integrate what we've learned to other times and spaces and context of the self. That's what generalization is. So we are unable to generalize the self. And how do we explain this? Well, not long ago, we did this huge, for anosognosia standards, study where we wanted for the first time not just to look at grey matter lesions, but to look at connectivity, so white matter disconnections. And we found the so-called salient network, to cut a long story short. So anatomically speaking, the most important dissociation in this syndrome seems to be something that in other areas of neuroscience we think is the system sort of linking insula with TPJ and other areas of these parts of the brain that monitor salience in different domains, from decision-making to sensory perception. So maybe we've been missing that. Maybe it's not exactly what you can or you cannot do, but taking into account all this, how they get integrated and balanced is what may be off with these patients. And then, I don't know if that happens to other people, but it happens to me a lot. Then I suddenly say in the lab, didn't we do a study on this a few years ago? So we did, and we had looked at spatial and social cognition in these patients, and we had actually found that they don't have perspective-taking problems. But if you do these kind of tasks, and I don't have time to take you through it, they have constant problems in doing allocentricity, as it's called in the social world. So this is when I think of you not from my perspective, not your perspective, but anyone's perspective. Whatever I think right now about giving you this lecture, I at the same time should know, and I'm able to know, that all of you have a perception of me. And therefore I exist not just for me, not just for any individual position, but for everybody, as an object or a person among others. That's what allocentricity means. And this was shown very carefully experimentally to be the case, and it was shown that these allocentric errors were the ones that correlated with the severity of self-awareness problems. And when you look quantitative and qualitatively of the source of the error, it's an ability to suppress the egocentricity, your own perspective, what you're thinking in the moment. And again, when we run lesion studies on this, we see parts of this network, the salience network. Okay, so this is a model we've long proposed, and I'm not talking about all of it here. But basically, it's quite similar to what Quinton was talking about today, but in a different context. So the idea is that we have a bodily self, we have the ability to perceive sensations and all of that, but that is nested. I won't say about the social today, that's a different talk. But then we also have other allocentric counterfactual beliefs about the self. And the relationship between the two doesn't need to be an either-or. That's why it's complex. But there are ways to quantify it if you study it carefully. And in these models, the key thing is how the relationship between the two is weighted at every instance. I talked about salience today, but you can think of other domains such as attention and other ways where you can perceive salience. So, okay, in the interest of time, this is really the conclusion. But I wanted to talk about anorexia. And the reason and interoception. I haven't said a lot about interoception yet. But the reason I wanted to do a neuropsychological detour first is because I think neuropsychology is a little bit better than neuropsychiatry in showing us some of these complexities, simply because you have such extreme deficits that you can get to some bits that are otherwise not so easy to reveal to the observer or to the scientist in psychiatry. But this is a similar thing that sort of inspired us, and we looked at that in anorexia. So similar to our model from neuropsychology, there is increasing these kind of Fristonian or predictive coding or predictive processing or active inference, depending in which exact field you belong, models that say that a similar thing is happening in many aspects of psychiatry, and particularly here in eating disorders. So there's not a lot of empirical, there's a lot of theory, but there's not a lot of empirical evidence, apart from this study that looked at, in a transdiagnostic study, but looked at 14 patients with eating disorders. But the idea is this, that they have this problem with precision or salience, as I showed you, so they're not paying the right kind of attention to their interoceptive signals, and that's causing them some of their problems, so they don't know how to be hungry in the right way, for example. However, like in anosognosia for the past 100 years, these models and the relative evidence are still looking at these retrospective beliefs, and they're really obsessed with perceptions, I like to see it. So they really want to know, what did you just experience? But as we saw, sometimes it's what we think about our ability more broadly that matters. So how do we think about the self counterfactually? And how are interoceptive monitoring difficulties combined with more general processes of belief updating? So we designed very similar tasks, but this time in different domains. So we do a task like the ones that Sarah showed you, for example, the problematic heartbeat counting task. We started these studies a long time ago, so some of the criticism wasn't expressed then. And we also deliberately wanted something simple because you do this in the ward. So you first, however, ask people of their prior beliefs. How well do you think you'll do? Then how many heartbeats did you count and what's your confidence? And then again, now how well do you think you do? And then we say, okay, now if I give you the double the time or half the time, how well do you think you'll do? And what we see first, at least in this study, but it's quite a big sample, there is no significant difference between acute restrictive anorexics, weight-restored anorexics, and healthy controls in actual interoceptive accuracy. In other terms, they're equally accurate, on average, in counting their own heartbeats. But if you ask in the beginning, how well do you think you'll do? There is a significant difference between the group, with the acute anorexic being far more pessimistic than the other group. So they think they'll do worse. They have less reduced self-efficacy if you're a clinical psychologist. And so we did, again, a little modeling to try to see what could go, what are the parameters behind the behavior. And we modeled beliefs based on accuracy. So let's say that the evidence now you have to consider to decide how you're going to form posterior beliefs are the heartbeat counting, your performance, and your confidence on it, versus beliefs based on how you think you did and your confidence on it. And what we're finding is that this is the better model. So not what you actually did physiologically, but not how accurate you were perceptually, I mean, but how accurate you thought you were. And if you take this model, then you see that the critical group is less optimal in updating. So their actual updates are closer to the priors than they should be if they were doing this Bayesian optimally. So there is something about, similarly to anosognosia somehow, it's not that it isn't in the signal, it's not that a signal doesn't matter, but it is that if I have strong prior beliefs, I'm going to disregard things, I'm going to draw my own conclusions, even if in the moment I was drawing the right conclusion. And just because we don't want to do things only with heart, we have started a study, but unfortunately we have to discontinue it, and we're going back to it now, that looks at water. So we're asking people, how full are you? How full will you be if you have to drink this much water? They have to drink it in front of us. We're always afraid they're going to say no, but so far we've managed everybody to accept it. And then we ask you how full you feel, and then we ask our perspective. How full will you be if you drink this amount or this amount or this amount? So similar idea. We don't have the computational modeling yet because this is not a complete study, but you can already see it. Anorexia, healthy controls. This is the prior beliefs. You see how it falls down. So when they actually drink the water, you say, yeah, I'm not that full. But then if you ask them how full will you be next time, they're up closer to the prior. Whereas the controls are staying there. Everybody's learning because you're somewhere in between, but they're learning much more from what happened. So we have preliminary support that anorexia patients have low self-efficacy about interoception, but neither their accuracy nor the retrospective metacognition are affected per se. Instead, it's the ability to form prospective self-efficacy beliefs based on the precision of retrospective beliefs that seems affected. Somehow similar to what I showed before in neuropsychology, but I hope I'm making the case that it's easier to see it when something is in action. It's a little bit like functional motor versus psychogenic amnesia. It's easier to see when somebody complains of paralysis. So, however, weight-restored patients are not showing so far such clear patterns, so we don't know to what degree this is also a secondary consequence of the anorexic state rather than the pathogenic mechanism itself. But if that's the case, if I'm arguing that we need to integrate the sensory bits and the top-down beliefs, we need to take both body and mind seriously, and we can potentially quantify how they come together, then how can we do that in therapy? So very similarly to Sarah, but with our usual metacognitive twists. So we provide interoceptive biofeedback, but we also combine that with classic metacognitive therapy. therapies, and we have done only, as part of an audit, a little pilot study where we ask people for their beliefs, we stress them, and we do that. This particular one was in an acute anorexic ward, which they have to do a meal planner, and it's very stressful, so we used a clinical stressor. And then we give them breathing exercises and biofeedback. So basically we give them feedback of their heart rate and how they can see it being upregulated by stress, and they can have agency in downregulating it themselves. But we don't stop there, which is most biofeedback studies stop. Then we ask them to tell us their belief and their prospective beliefs, and we work with them in belief updating. And we're very happy to say with Caroline's slide, that I think is here somewhere, that we got from the Institute of Mental Health at UCL, that Anthony David leads a grant to do a bigger subclinical trial on this. But just to show you the pilot data, so this is our 6 severely restrictive anorexia. They don't eat at all, and they are really freaked out, but all interoceptive signals. And this is before and after training in terms of how confident they feel in regulating their own heart rate. And even though statistically this is just literally that, 6 patients, no controls. And this is in comparison to standard treatment, which was mindfulness, because it was an audit. You see that everybody, for a very different starting point, but everybody has a positive impact of the biofeedback. And comments, I don't often know when I get stressed, so the biofeedback help. I think seeing my pulse changes could give me warnings. I'm bad at understanding my body, so biofeedback would help me know when I am starting to escalate. Often, with mindfulness, I don't know if it's working. I don't know if my heart rate is going down. And I'm also not sure when to start the breathing exercises. I don't notice the anxiety build up, it just hits me, which is what I'm trying to demonstrate, that if you take a purely somatic therapy, that's the kind of problems you have. If you take a purely belief or narrative self kind of therapy, then you're missing the whole interoceptive conundrum. So it's about trying to find ways to bring them together. And this is a little theoretical model of the nested hierarchy of our self-concepts, which is important. Because if you have a nested hierarchy, what it simply means is that if you have a problem in one level, any problem, you will see problems in other levels, frequently an overcompensation. I hear, for example, in the FND literature, too much attention to the symptom. Why isn't anybody asking where is the less attention? What is it that they are not paying attention to is equally important. The too much attention that I literally can't walk, because that happens to you if you pay too much attention to walking, which is supposed to be automatic, to come back to Sarah's wonderful graph. And there is a big, tradition, some of you know from the alexithymia world, the Sifneos work, somatization work, where they said it's not what Freud thought, it's like trying to make the unconscious conscious. It's the opposite. What we're trying to do, Sarah, your graph, is make what is abnormally conscious to be normally automatized again, to become unconscious. That's what we're hoping this nested hierarchy is. It means if I need to think about this, because otherwise I won't give a good talk, then I need to inhibit this. But if this is too busy, interoceptively, I can't inhibit, I'm going to pay attention to it because it's calling for my attention. Right, let me thank the researchers who actually do the work, the many clinicians and collaborators that are brilliant, and then many more than I can fit in my slides, but I do spend a lot of time working with clinicians before I do any research, because I think you know all the answers, actually. And of course, the funders and you for your attention. Thank you.